I'm Dr. Nidhi Darji, specialist ophthalmologist at NMC Medical Center, Shahba. I have more than 10 years of experience in this field, and I'm mainly specialized in the anterior segment surgeries like cataract surgeries by advanced phacoemulsification technique and the other refractive procedures like LASIK, PRK, etc. I've also done a fellowship in the medical retina wherein we treat various retinal conditions like diabetic retinopathy, hypertensive retinopathy by modalities like lasers and intravitreal injections. So today I'll be discussing about the diabetic eye disease, or the most common is the diabetic retinopathy, how diabetes affect the eye and damage your eye or the vision. I'm going to discuss in detail about this. So diabetic retinopathy is the disease of the eye where retina is damaged due to high blood sugar levels. Now let me tell what retina is. Retina is a part of the eyeball, that is the innermost layer of the eye, where all the rays or the images are being captured or the focus there, and then the signals are transmitted to the brain. Our eye is like a camera. They capture the image and projects outside so that we can see it. The images are transmitted in the form of electric signals through the retina or via the nerve, the optic nerve, to the brain, and the image is captured in the brain and we see. So in the diabetes, the retina is a very retinal blood vessels, to be precise, because of the high blood sugar levels, the retinal blood vessels are being damaged and it affects the retinal tissues and it damages the retina, and thus the vision is affected, the vision is compromised. It may lead to loss of vision or the blindness if not treated properly or timely care is not taken. Patients with the diabetes may get the diabetic related retinopathy. I will not say that all the patients will get the diabetic retinopathy or the diabetic eye disease, but those patients, the patients who are on the high risk, are uncontrolled blood sugar levels, whose blood sugar levels are not under control, their HbA1c levels are high, or second is the chronicity of the diabetes. Those who have the diabetes since more than 5 years or the 10 years, those with the more than 10 years of diabetes are higher risk of getting a diabetic retinopathy as compared to the patients with the less than 5 years. But that doesn't mean that the patient who has been diagnosed very recently will not have any diabetic eye changes. So of course the type 1 diabetes mellitus patient, type 2 gestational diabetic patients, then also the patients who have other associated disease like other disease like hypertension, hyperlipidemia, hypercholesterolemia, they are also prone for getting this retinal damage. Other risk factors like smokers, then uncontrolled diabetes, all these are the risk factors for the diabetic retinopathy. So the symptoms depends on the stage of diabetic retinopathy. So sometimes in the patient with the early stages may not have any symptoms. They will not have any symptoms if there are some very mild or the moderate diabetic changes are going on in the retina, and that is the reason we recommend all the patients to go for the eye screening, especially the retina checkup, every year or once in a year. But the other symptoms like blurry vision, floaters, distorted vision, distorted reading vision or the far vision, frequent changes of the glasses, not comfortable with the glasses, then floaters or the flashes of light when the patient present at the advanced stage, then the other symptoms of the hemorrhage or the bleeding inside the eyes, like a sudden showering of blood in front of the or in the field of vision. So these are the symptoms patient will feel. So there are various classifications for the different staging of diabetic retinopathy, but the standard is the ETDRS classification, in which says that they have divided into non-proliferative and the proliferative diabetic retinopathy. So the non-proliferative is like a mild, moderate and the severe. I'll not go much detail into the different characteristic or the signs in each stage, but the non-proliferative is wherein we see the mild, moderate, where the vision is not compromised that much, and the signs are like a few pinpoint hemorrhages, microaneurysms, or some collection of the fluid, we call it as exudates. Whereas in the severe, there are some more sized, the blot hemorrhages are there, more hard exudates or the bigger size exudates, even the macula is involved. We call it as a maculopathy, diabetic maculopathy. Macula is the center portion of the retina, which gets involved in some patients due to collection of the fluid in the layers of the macula, and that affects the center vision, that affects the vision of the patient, and which has to be treated promptly. Another is this, or the non-proliferative. Another is a proliferative diabetic retinopathy. Proliferative means the proliferation of the new blood vessels, wherein because of the ischemia, because of the high blood sugar levels, the retinal blood vessels gets fragile and it leaks out the fluid, or it leads to hemorrhage. They are so fragile that they burst and leads to retinal hemorrhage, and because of which there is a lack of oxygenation into the retinal tissues or the surrounding retina, and this hypoxic damage of the retina leads to formation of the new blood vessels. We call it as a neovascularization, and this neovascularization of the retina is called proliferative. It falls under the proliferative diabetic retinopathy, and this is more dangerous, or you can say if patient presents with the proliferative diabetic retinopathy or in the advanced stages, it's leads to vitreous hemorrhage, retinal hemorrhage, some tractional retinal detachment, and that the prognosis at that level is very bad. You can say it's irreversible. The damage at the advanced or the proliferative stage is irreversible. There are various modalities which are available nowadays. The various scans or the images, the retinal image photography are available, but the basic or the comprehensive eye checkup, the normal eye checkup is very important, in which we check the visual acuity, your retina, the dilated eye checkup, or the dilated ophthalmoscopy or the fundoscopy, what we call it as, is necessary for all the diabetic patients. So we recommend once in a year go for the routine eye checkup. There's no special equipment required for this, but go for the routine dilated retina checkup. And if your ophthalmologist finds any diabetic changes in your retina, then he or she will advise to go for the further checkup like fundus photography or the OCT scan. If there are some signs of the maculopathy is present, then we advise the OCT scan of the macula to look for the damage or the damage in the retinal tissue, or to check the macular thickness. So all these modalities are there, but go for the basic dilated retina checkup to detect the early changes of the diabetic retinopathy, and based on which we further advise some investigation. So yes, there are treatments available for the diabetic retinopathy, again based on the stage of diabetic retinopathy. So one is in the form of retinal lasers, and another is the retinal injections. Let me just talk to you about the retinal laser first. Retinal laser is called pan-retinal photocoagulation, wherein 2 or 3 sittings of argon laser is done in one's eye, in which we apply the laser and burn the retinal tissue which are already damaged, thus diverting the flow of healthy retinal circulation, or you can say the oxygenation from the unhealthy or the damaged retina to the healthy retinal tissue. So like this, the retinal laser works. So when the patient presents to us at the stage called moderate to severe NPDR or the non-proliferative diabetic retinopathy, we advise retinal lasers, especially when there is no macula is involved. and we stabilize the retina so that the further progression can be stopped, or we can monitor. So sometimes 2 or 3 retinal laser sittings or more are required depending on the patient's stage. Another treatment modality is which is available is injections. Your doctor might advise you the retinal injections, that is anti-VEGF injections like bevacizumab, ranibizumab and Avastin. All these injections are available. So this is mainly advised for the maculopathy, wherein the fluid is collected in the center layers of the retina, and by giving this injection we can treat the maculopathy. And also we do the OCT scan before advising these injections, and we monitor depending on again the macular thickness and your OCT finding. The number of injections are decided. Of course, other factors we take into consideration like visual acuity of the patient, how patient is improving vision wise, the OCT scan, the macular thickness, etc. So to avoid, if you are a diabetic, if you have the diabetes, then I would advise to go for the routine eye checkup and screening. Screening is very important. The prevention is always better than the cure, because the cure in the diabetic retinopathy is to stop the further progression. As we know that some damage at the level of retina is irreversible. So to avoid getting diabetic retinopathy, number one is a strict control of the blood sugar levels. You should be very compliant with your medicine, the timely follow-up with your diabetic doctor, the lifestyle modifications and the strict diet control. All these are very necessary in order not to get the eye disease which is related to the diabetic. And also the timely or the annual diabetic eye checkup which your ophthalmologist recommend, maybe annual or 6 monthly depending on your ophthalmologist suggestion. So this is how you can prevent getting diabetic retinopathy. Again, the strict blood control, strict control of the blood sugar level is very important. So to all the diabetic patients, be it type 1 or type 2, be it controlled or uncontrolled, the recently diagnosed or an old diabetic patients, we recommend go for the annual or the once in a year dilated retina checkup. When you go for the checkup and your doctor diagnose the diabetic retinopathy and they say that okay, you have the mild or the moderate this diabetic retinopathy, depending on the stage, the doctor will advise the further test. If not required, then the further follow-up. If some patients present at the early stage, so at that stage we don't do any treatment like retinal lasers or something, but we just monitor for the further progression. We just call the patients more frequently rather than calling once in a year. We call them after like 6 months to just check for the progression. We sometimes even advise to take one scan or the fundus photograph, and we do it again to compare it with the previous retinal scan or the photograph if there is any progression or not. And based on the progression, again compliance of the patient with the medicine and the blood sugar, we advise the further follow-up. So follow-up or the eye checkup is advised based on many factors, the patient's signs and the symptoms, how compliant the patient is with the doctor or with the medicine, and based on the finding of the retinopathy, we advise the follow-up. So the prognosis of this disease depends on the stage of presentation, and as I repeatedly say, many factors, how the blood sugar levels are controlled, the chronicity of the diabetes, and yes, at certain stage it is not reversible. The changes or the damage at the level of the retina is irreversible, and that is the reason we advise the timely follow-up, so that we can capture or we can diagnose the disease at the early stage and we can take further management. We can prevent the further progression of the diabetic retinopathy, in order to prevent the diabetes related blindness. Because some patients present to us at the very advanced stage, like at the proliferative diabetes, some patients present with the sudden loss of vision due to vitreous hemorrhage, that is bleeding inside the eye, and at this stage we only, sometimes the only option is to wait and watch. If the bleeding doesn't get resolved, we advise we go for the surgery. That is, surgery remains the only option, or the injections are the options for such patients. And so that is how the prognosis is, depends on the stage of presentation. So we discussed more about the retinopathy, that is, retina is of course involved in the diabetes, but apart from the retinopathy, diabetes also affects the other parts of the eye, like it leads to cataract. Diabetes related cataract is also very common. It leads to the cataract at a little early age, or the earlier as compared to the age related cataract, or the senile cataract, which comes little bit later age. And also it leads to glaucoma. Diabetes also leads to, we call it neuropathy. And neuropathy, one of the nerve which is supplying, like a third nerve, fourth nerve, sixth nerve, which is supplying the eye muscle, gets paralyzed and leads to paralysis of one of the nerve, and it affects the eye muscle. And sometimes patient presents with us the double vision, deviation of the eyeball, and this is nothing but the paralysis, and that is because of the diabetes which patient gets into the eye. That is sometimes the sixth nerve paralysis, which leads to deviation of the eye. So this is also very common. Then it is a neuropathy, although it affects the eye, but it is a neuropathy. So to sum up, I would like to advise to all the diabetic patients to go for the routine eye checkup and get your retina checked once in a year, or as per advice by your ophthalmologist. And again, it's in your hand to control your blood sugar levels in order not to get into the diabetic retinopathy disease. So strict control of the diet, the exercising, and taking the medicine, and controlling your blood sugar level, and timely check up with your endocrinologist and the ophthalmologist as per advised is very, very important. Thank you so much for listening to me. Hope you gained the enough knowledge about the diabetic retinopathy or the diabetic eye disease.